Welcome, everyone. Good afternoon, and I'd really like to welcome you to today's session. Today's session is about what is tomorrow's modern technology ecosystem look like for healthcare. I'm Maddie Schults, Senior Director of Product at Innovaccer. I lead the product for our Gravity platform. Quick plug, we have a session at 3:45, another breakout right in this room. So for some of you, you can just stay here. But I am accompanied by 4 amazing leaders today. And I would like to introduce you all to them. And today we're going to explore, how healthcare organizations can move from having these fragmented point solutions to truly connected ecosystems, right? So let me introduce you to one sitting right next to me, Dima Goncharov. He's the co-founder and CEO of Metriport. Metriport is an open source platform transforming healthcare data exchange. With a background as a software engineer, Dima has built everything from aerospace and defense mission systems to highly available cloud database services at Amazon Web Services. Prior to launching Metriport in 2021, he worked on Amazon Aurora, contributing to its reputation as a reliable and performant database platform. Dima's passion for transparent, secure, and accessible health data solutions is evident in Metriport's mission and the APIs they've developed for seamless medical record retrieval. Dima is an alumnus of both British Columbia Institute of Technology and Y Combinator's Summer 2022 cohort. Now based in San Francisco, he leads Metriport's efforts to modernize and open up healthcare interoperability for providers everywhere. Next is Dr. Timothy Puri. He is the Chief Medical Officer for Population Health at Curana. It's a healthcare services and technology organization supporting over 200,000 seniors annually across more than 2,000 communities in over 30 states. Wow. Curana operates at enterprise scale across complex multi-vendor healthcare environments and has been recognized as one of the fastest growing healthcare companies in the country. Dr. Puri is a practicing physician and clinical operator with hands-on experience leading large-scale population health and value-based care programs. His work sits at the intersection of clinical care data and operations with a focus on translating analytics and AI into trusted in workflow action that clinicians actually adopt at scale. So we're going to hear a lot of good things there. Next is our partner, Patrick Kovalik, industry principal for healthcare payers and providers from Snowflake. He's a global industry leader at Snowflake, focusing on modern data and AI solutions and strategies for the payer and provider segments. He has spent his career delivering innovative solutions, process improvement, and data management initiatives for data-driven business decisions and metrics improvement. Prior to Snowflake, Patrick has spent a decade doing operations, analytics, solution development, you name it, for Texas Health Plan within a Fortune 50 managed care organizations, and then also connecting business leaders to data for improved care management outcomes and performance measurement. Thank you for joining us, Patrick. And last but not the least, our resident data nerd. That is, he calls himself that. This is career data. Thank you, Mike. Mike Sutten is a prominent technology executive, currently serving as a technology advisor and former chief technology officer known for leading digital transformations at major healthcare and corporations like Kaiser, Central Intelligence Agency, and many more. Currently, he joined Innovaccer in November 2019. He's our chief digital officer and chief technology officer, and he's advisor to a lot of things around here. So thank you for joining us, Mike. All right, these are our amazing 4 leaders that we have, so let's kind of dive in. So from where you folks sit today, what's the hardest thing about innovating in healthcare, given the number of systems, number of vendors that we have? Who wants to go first?
Right. From like our perspective, we have essentially like a service that is a one-stop shop API that gives you access to the clinical histories of over 300 million individuals in the US. And to bring this service to life, dealing with a bunch of platforms, vendors, data sources is essentially like the bread and butter problem that we're solving. And the hardest part is exactly that. Like you have one format, let's say you call it FHIR, so let's say you call it CCDAs. The reality is you have like 5 vendors and they interpret the same standard in 5 different ways. So we'll get into this like a bit later in the lecture. But that's exactly it. It's like all the vendors, all the standards, all the different data sources. Even for the standards, they're not so standard. And even across the same vendor, you may have different facilities that say A1Cs in 50 different ways. So.
Yeah, for us, thanks, Dima. For us, the impact of fragmentation really is the gap between when we get the clinical insight and then how we actually get that insight delivered in care. And because of the fragmentation, the insights are often, we have a ton of EHRs, we have a ton of HIEs, we have a ton of claims, we have PBMs. A lot of the work, when we get an insight, those things don't line up, right? Attribution dates don't line up. Like you said, the ways that, costs and addresses don't line up. And so our clinicians spend a lot of time like reconciling things as opposed to actually taking action on these things. I'll give you guys an example. Skin substitutes was a big issue last year. It's going to probably, do some stuff this year. We knew it was going to be an issue, but we didn't have a way to sort of know where, and so we had to wait for claims to come in. Finally, we got claims a few months later. We figured out some high-cost patients, but by the time we were able to clean all that up and get it to our clinicians, some of those patients had died, the skin substitutes had stopped. We couldn't figure out which wound care provider was delivering this. We didn't have access to their EHR. So the whole thing just took a ton of people to actually get impact. And I think fragmentation leads to that friction, and then people just kind of stop trusting it, which makes things a lot slower.
Tough to add new points on there. Good foundation. I mean, I think that's the theme. That's why everybody's in this room. It's hard because it's always been hard. Like there's too many formats, too many volumes. I mean, the latest hard I talk about is even, especially with the explosion of AI, is just semantics. I think you guys just started to tease it, but if I asked you guys an active member or an active patient, how many, would I get one answer? Or I'm a diabetic. If I said how many diabetics in my population, your first question should be, well, what do you mean? Like type 1, type 2. So of the hard, it's just it never ends. And so you have to be able to keep keeping up, and sometimes the first build of the solution's brilliant, and then the next refresh comes in more. So I think just sometimes the way to tackle the hard is to keep asking what else is out there, who's doing it better, how do you keep language, semantics, systems, formats. But if you're new to healthcare, welcome to healthcare.
Thanks, Patrick. Yeah, so Dima talked about variety. That's certainly a problem in healthcare. Same source, data looks different. Payers, for some reason, randomize files and send them to us, and we try to have to interpret those. So the variety problem is a killer in the healthcare space. Dr. Puri talked about the actual, not variety, the veracity of the data. You can't trust it. Forget the format problem. You don't know what the quality of that data coming at you. Patrick referred to the kind of volume, and I think, having run an enterprise IT shop for a large healthcare system, the simplest problem is the sheer volume. Like, I'm fortunate in my position at Innovaccer. I get to talk to a lot of CIOs and chief data officers across enterprises, and the sheer volume of applications that require integration is mind-boggling. Like, for example, I don't think there's a single CIO I've talked to that doesn't have less than 400 applications, all of which require some degree of interoperation and interoperability together. And then great, we have APIs, but can you trust those data in those APIs? The health system I used to work for, we were proud that we got it down to 1,800 applications. And these are hundreds and hundreds of people required, because this is not an autonomic process. It is batch jobs that people have to watch. They fail. They're expensive. And then the other thing is, they're not just one. It just doesn't go one way. A simple application like an HR system, you might think is fairly straightforward. We had over 150 integrations with that. And guess what? We went to the cloud vendor, we went back on-prem, we went back to the cloud vendor, then we had to send the data to another cloud vendor, and then just to get it back for us. They're entirely complex and expensive to maintain. So I think that's generally, I'm not saying volume's the only problem, but the fact there's so many applications out there is a very compromising situation.
Oh, yeah, I mean, yeah, it's interesting to kind of hear the challenges, and still what I'm hearing from all of you is really that foundational data, right? That is what is still the biggest problem that we have to unlock to really innovate in healthcare. This question is for Dr. Puri, is from a population health and clinical leadership perspective, where do initiatives break down on a day-to-day basis for clinicians?
Yeah, they break down in a lot of places, unfortunately. But specifically on a population health level, I think what we see is because people in population health believe that these initiatives really will impact patients. And so what we do is we do pilots. And we say, okay, if we're going to pilot this with this group of patients, with this group of clinicians, we're going to show some impact, then everybody's going to say, wow, and then it's just going to explode. The problem is when you do pilots, you sort of build on these clinical heroes, and that just doesn't scale. And so now what you've done is you've created a single instance of a very customized solution, even though you think it's big. And when you try to scale it, now you have 10 of those heroes. They all know something different. They all have built it slightly differently. And then the average clinician user just wants their day to be easy and frictionless. They don't really care about FHIR and HL7 and they care about single sign-on. But so you get this building the system for heroes, not for systems, and it increases fragmentation, and then you really don't get the outcome you want.
Any technology perspectives from Patrick or Mike on this?
You want to go first?
The one I would kind of add, so given the complexity of the data part of it, I think organizations, it's difficult to understand how does a CFO appreciate how much money is being spent in this particular area, and how do we articulate that, I think is one of the things we need to improve on how we do this. So.
Next question is for Dima. In terms of standards-based exchange, we have some very well-defined standards. Where do you see organizations still kind of struggling with integrating this, incorporating those standards, enforcing them, and so forth?
Yeah, so what we see typically is we work with a healthcare organization, and then they say why should we even use your platform in the first place? And we're like, well, because it's useful. And they're like, why is it useful? So typically the conversations that we're having with healthcare organizations is they've integrated with a state HIE. And they're like, we've already done this before. We know how to do it. The next one we'll just do again and no worries. And then we're like, hey, which state HIE did you integrate with? And they're like, hey, I integrated with one in South Texas. We're like, okay, you've integrated with the South Texas HIE, and that's it. Because as soon as you move on to the next one, all of those standards that they say are standardized are not. The integration looks different, the data looks different, they're using the same HL7 FHIR, whatever, but all those specs look different. So that's the biggest challenge that we see organizations come across, is that they think they've done it before, but they're looking at a sample set of n equals 3 or n equals 5. And it's to truly solve the problem, you need to look at n equals 300 million, because patient records are represented different. We were talking about different vendors. Some vendors, even if they're the same across different systems, will represent the same thing differently. Mm-hmm. So maybe you've integrated with one state HIE, maybe you've integrated with one ADT feed, maybe you've integrated with one national exchange. The exchanges are different. They have different endpoints. It's different standards. So that's a common failure point that we see is oh, we've done this before. And it's yeah, you've done it with that one system before.
Wow, lots of complexities. I want to kind of dig into more data complexities, because that's where I feel the gravity is. So in terms of, yeah, there was a little pun in there. Many healthcare organizations say okay, we have invested in data, we have a data lake, But what we're hearing from you all, and then also from other conversations, that they're still kind of struggling with that to get like consistency from their data in terms of either analytics and insights about their organization. How do I transform this particular business or improve my patient experience? So Patrick, like, what do you think distinguishes a truly like unified data foundation from whatever the healthcare organizations have today?
Sure. I mean, we joked about it clinically, but if I ask the same question to you guys of like, what is a data lake? I assume I'd get 20 different answers too. I mean, the beauty of that is storage of data is what's become super easy. So that almost even, exasperates the problem of like, now I can take any format, any volume. Multimodal data is now accessible in an instant. I used to have to have silos of my medical data to maybe behavioral or to pharmacy or to vision, and I used to have to MacGyver them all together only when I needed it. And today it's all fair game, and now I can get into audio files and video files and DICOM images, and it's all fair game. So when you add that mess, the lakeside is sometimes what's too easy because that adds a lot of problems. So then you get into master data management and semantics and what's the lineage or the